So where do we stand this week from a COVID standpoint? Compared to last week, our inpatient volumes have doubled. So we have approximately 20 patients admitted in the hospital today with COVID. 75% of those, or approximately 15 of those, are acutely ill. The other 5 are children who are admitted for other reasons who have tested positive for COVID. We have 5 children in our intensive care unit this morning with COVID, and 2 of those are ventilated. At least 1 child in the ICU has no underlying conditions and no past medical history that would put him or her at risk for being in the ICU, thus underscoring the importance of understanding that while COVID primarily affects adults much more severely than it does children. And when it does affect children, it is generally affecting children with underlying medical conditions. It is not entirely outside the realm of possibility. In fact, it does happen that children who are generally healthy do get COVID and can get sick and end up in our intensive care unit. From an RSV perspective, or respiratory syncytial virus perspective, we have approximately 40 children admitted to the hospital today. And influenza, we have 0 children in the hospital. And as a reminder from RSV, that is exceptionally atypical for the summer. This is volumes that we would typically see in the winter months, not in the summer months. Our emergency departments and urgent cares continue to be quite busy. Their volumes are much higher than usual for the summer months, and they are seeing quite a few children coming in with respiratory symptoms consistent with viral illnesses, including COVID. Our COVID testing site that we run also has seen exceptionally high volumes. In fact, we are testing more children for COVID now than we had even at the peak of last winter. So that is a reflection of the increased spread in the community. From a capacity standpoint, we are at about 70% capacity today, with adequate capacity in our intensive care units to continue to care and meet all the needs of the children around Central Ohio and beyond. We are not on any sense of diversion, and we have not turned patients away, and we are continuing to take patients from referring hospitals who need pediatric care. I should say that our staffing is much better this week and stronger this week than it had been in the prior weeks, which is making the overall stress on the healthcare system seem less than it had been in the past couple of weeks. So I really want to thank our nursing staff and others who have stepped up to the plate and picked up extra shifts to help meet the demands, the surprising demands of the patients that have come to our organization. So this is something that we typically deal with in winter months. We have staffing plans to address volumes, as Leanne Wallace spoke about last week, and we've been very fortunate that our staff have really stepped up to the plate to help us during this unexpected summer surge of patients. So while I'm really optimistic about our clinical operations in general, due in large part to our staffing and our ability to have open beds and continue to care for patients, it is concerning to see that the pediatric volume of COVID patients in just 1 week in our hospital has doubled. And when you take into consideration what is going on in the southern states, and you take into consideration that all of our schools are now open in Central Ohio, I think the next couple of weeks, this could be very concerning if we do not take immediate actions around 2 real key factors. One, getting vaccinated if you are at all eligible to be vaccinated. And the second one is aggressive masking, especially in schools, as well as around large social gatherings. So those will be my comments for today. I'm going to turn it over to Dr. Ramillo to talk more about the respiratory syncytial virus, RSV, and any comments he'd like to add around COVID.
Thank you, Dr. Morse. My name is Dr. Ramillo. I'm the head of infectious diseases. I think it's important what Dr. Morse just pointed out, that we are dealing with 2 outbreaks. Our COVID outbreak that unfortunately is coming up to a pace that we did not anticipate, and concomitantly RSV. As you know, RSV is an old friend, unfortunately. Every winter we have a big outbreak. It's the most frequent viruses that gets children in the hospital. Indeed, when you look at the causes for hospitalization in the first year of life, RSV alone is the most frequent one in the US and around the world. And it's so frequent that by age 2, 95% of all children have had at least one infection by RSV. In our country, in most of the developed world, RSV causes tremendous hospitalizations, but not deaths. Unfortunately, that is not the case in the low middle income countries, because when you look at causes of death in the first year of life after malaria, RSV is number 2. So it's a really important issue. And why is so challenging? Because it affects young children, mostly in the first year of life and mostly less than 6 months of life. So those are children with a very mature immune system who are not able to make antibodies, right? The protein that protect us against infections. For that reason, the development of a vaccine for RSV has been very challenging. We've been working many groups around the world for 40 years. And I'm happy to tell you that for the last 10 years, we've made a lot of progress. For instance, we learned that baby's immune system, the baby's white cells that make antibodies, are not so easy to respond to vaccines. So we thought the alternatives to give the babies the antibodies, to give the baby the protection. And there's a number of studies in the last 5 years that I think we are very, very close to have final results to give antibodies to the babies. How we do that? 2 major strategies. One is to vaccinate moms. If we vaccinate pregnant women, they make their own antibodies and they can transfer those antibodies to the baby across the placenta. That will make protection for the babies for the first 6 months of life, which are the most critical ones. The second alternative is to give these antibodies to the baby. We can give these monoclonal antibodies at the beginning of the season that will protect them over the course of the whole 6 months of the epidemic. So we hope there are now 2 major studies with maternal vaccines and 2 major studies with these monoclonal antibodies, and we hope to, in the next 18 to 24 months, we may have these products available to prevent RSV. Again, as Dr. Morse mentioned, these young babies are really RSV is causing this epidemic in these young babies so early. The numbers that we are seeing now with 40% positivity rate on the testing is what we see usually in Columbus in December, and this is adding to the stress to the COVID pandemic. That is why we are trying to encourage. So going back, we need to encourage everybody to get vaccinated. I read the data from this morning, and even in the population of children that can get vaccinated, the 12 to 17-year-old, only 50% have got 1 dose. We need to do much, much better. We need to get those numbers up to 90, 95%. We need to get everybody in school vaccinated, students, teachers, staff. And not only that, we continue to have to use masks, exactly as Dr. Morse pointed out, in all social gatherings and inside the school.
Thank you, Dr. Romero. I appreciate those comments. So the vaccine efforts around RSV, just to summarize again, you're focusing on the parents, the mom getting the vaccine.
Correct. This is very interesting because we always thought in babies, we usually give the vaccines, right, when they are 2, 4, and 6 months to boost the ability of the white cells to make these protective molecules, the antibodies. However, most of the babies who get very sick with RSV are very young, so there's too early to immunize them, to give them the vaccines. So alternative is to give them the antibodies directly. So by vaccinating pregnant women and to get them to make antibodies, we can transfer, and we know there's studies showing that transfer significant amount of protective antibodies to the baby. So this is extremely exciting because, Rusty, for the first time in 40 years, as pediatricians, we will have a tool. The second tool, also very technologically advantaged, is to give the antibodies directly to the baby. We have now, there's 2 or 3 companies have made these very potent antibodies that you can give only 1 dose, IM, 1 shot, and can prevent RSV for the next 6 months. That's what we need, and we hope to get them into the clinical setting in the next 18 months.
Well, that's exciting. That would be a game changer for us.
Absolutely, will be a game changer.
RSV.
As in pediatrics, yes.
So turning it back over to you, Gina, are there any questions or anyone from the chat who has comments or questions or wants clarification?
Thank you so much, Dr. Morse. This is Caitlin. I'll be moderating the Q&A today. So I'm taking a look at everything. I have a question. We'll start off a question from 10TV for you, Dr. Morse, specifically. You mentioned aggressive masking is definitely needed in schools. What is your message to districts that have not yet adopted mask policies?
Yeah, I think now is the time to do so. I mean, we are seeing, if you look at what's happened in the southern states, we are seeing aggressive spread within schools of COVID, and we are seeing some spread here within Ohio. So It is an opportune time, in my opinion, to put a temporary mandatory masking guideline in place for all ages, including teachers within schools, just to get us through the next few weeks. And let's get through this Delta variant, and then we can loosen that up. There's really no downside on masking. There's only upside from a safety perspective for the students and teachers and all those who come in contact with those people.
Great. Thank you so much. I have a second question.
Dr.
This is
Ramillo has
from,
just
oh,
Dr. Ramillo
perfect.
has
Go
an-
ahead, Dr. Ramillo.
I cannot emphasize what Dr. Morse has done strongly enough. I agree with him 120%. This is the time to increase this procedure, masking, to protect. In the last few weeks, I've been able to take care personally of many of these kids with COVID, and it's extremely sad when you take care of a kid with COVID and you find out that he has lost or she has lost a parent or an aunt, and this could have been prevented by vaccination and masking. We cannot not do it. So I cannot support strongly enough Dr. Morse.
Thank you both very much. Our next question is from Spectrum News. It's also for Dr. Morse. Dr. Morse, could you provide an update on whether the return to school for Central Ohio districts, some without masks, is contributing to the increases in COVID?
Yeah, it's impossible to know for sure. I mean, we know the Delta variant is highly contagious. You are more likely to get it and spread it if you are unvaccinated, but you can still spread it if you are vaccinated, which is why masking is important for all of us at this point. But there's no way to have an exact linkage between the school starting and their mask policies and what we're seeing in the hospital.
Great, thank you. Our next question is from ABC6. Wondering why we are seeing the spike in RSV now. Why is the timing happening now? Is there any relation to COVID-19 in this regard?
Obviously, last year, we did not have a classic RSV season between November and April, right? So we skipped one. So you can argue that this is maybe a late season instead of being an early season because we skipped one. We feel that several factors have contributed to do this. We have seen that the Southern Hemisphere also had atypical RSV before we had it. So we definitely think that the pandemic and the measures that we took for social distancing have contributed, but I don't think we have at this point yet all the explanation. No matter what, we need to take care of it now, and we have to encourage all the hygienic measures. For instance, young babies do not go to crowded situations. They don't belong into big areas, big gatherings. Babies need to be at home and need to be hyper protective. We know that usually it's the older sibling, the school-age kids who is 4 or 5, who brings the virus home. Usually those older children have a very mild disease, a mild runny nose. But when they give this virus to the young baby, it can go to the lung and cause a specific lung infection that will cause bronchiolitis. And then is when they can get very sick. So yes, we need to be overprotective on these young babies.
Thanks very much, Dr. Ramillo. I appreciate that. Our next question is from WDTN. Should the current quarantine guidelines for children in schools be adjusted because of the outbreaks?
I think we've been working with the public health officials and have been pretty clear that the decisions around quarantining and how to manage school COVID tracing and exposures needs to be made at a local level in conjunction with the public health official. So I would continue to suggest that our local health leaders in the schools work with their local public health officials to decide what's best in their individual circumstances.
Thank you, Dr. Morse. We've had a request just to repeat how many kids are in hospital or ICU with COVID. Dr. Morse, if you could just go through that data, that would be helpful.
Sure. So first of all, these are dynamic numbers. They're not static and they change every hour. But as of this morning, we had approximately 20 children in the hospital who had tested positive for COVID. Every single patient who is admitted to the hospital is tested, so we know that we have 20 who are positive for COVID. 75% of those, or approximately 15, are symptomatic, meaning they came in with symptoms of COVID. The other 5 were patients who were here for another reason who just tested positive for COVID. This morning, at the time I had checked, we had 5 children in our intensive care unit. 2 of whom were on the ventilator, meaning they had a breathing tube breathing for them. Most of those children have underlying conditions, but not all of them. There's at least one child in our ICU who is perfectly healthy prior to getting COVID, who now has symptomatic disease and is in our intensive care unit. And from an RSV perspective, we have approximately 40 children in the hospital this morning. And I should mention the 20 children hospitalized with COVID this Monday morning is twice the number that we had 1 week ago.
Thank you for repeating that, Dr. Morse. That's appreciated. A couple more questions here in the chat. Some parents are sending their kids to school with mild symptoms that turn out to be COVID. Should parents keep kids home if they have any symptoms at all?
Yeah, every school district seems to have slightly different guidance on this, which is why it's really important to work with your local school district to understand what the guidance is around symptoms. I can tell you just generically, if you are wearing a mask, even if you have slight symptoms, your risk of spreading that beyond to other students is remarkably lower than if you are not wearing a mask and the other students are not wearing a mask, which is why masking is so important. But I would look to the local school districts for those parents to be advised as to when they should send their kids to school versus which symptoms they should keep them home for.
Thank you, Dr. Morrison. Follow up there, is there contact tracing in the schools to make sure parents of kids who have been exposed know it immediately in order to control the possible spread?
And again, that's a local decision on how that's managed in conjunction with the public health officials. So it's something that you could ask the local school district how they're managing contact tracing.
Great, thank you. One more question. I hear from a lot of parents who are more scared of the risks of the coronavirus vaccine than they are of the risks from their kid getting COVID. Can you talk about the difference in risk for kids from coronavirus and the risk for eligible kids from the vaccine?
There's almost no risk to getting the vaccine. It's been proven to be quite safe, quite effective, over 350 million doses given in this country alone. And yet there are countless stories that are coming out from well-validated sources of people who have chosen not to get the vaccine, who are either critically ill or whom have died of COVID. So the risk-benefit ratio is far in the favor of someone who is eligible for getting the vaccine to get the vaccine than to take their chances with this disease, where true, a vast majority of people, including children, will be fine, but some children and more adults will die from this disease. Dr. Ramillo, anything else you want to add?
Yes, that's a very, very good point. Number one, we know that the side effects of the vaccine, although uncomfortable, they don't have any severe complications. And the data that we have on the adolescents, on children 12 to 17, is very positive. Number one, they tolerate the vaccine really well. And second, they make really good response. So they make good antibody response that is extremely protective. So from that perspective, the data are very, very clear. Now, Dr. Morse brought something very, very important. I think we want to transmit to all parents. The great majority of the kids do well, but we don't know who is going to be the one that does poorly and end up in the ICU. And that for that parent, that is 100%. That's the consideration that we need to take in why we recommend vaccine for the parents, the families, but also the children already. We can vaccinate those 17 to 12. And by increasing the number of vaccinated people in the school, the chances statistically that anybody can pass the virus around together with the mask will be very low. So there is a lot that we can do. I think we tend to get worried, get concerned, and totally understand. But we need to look at the positive side. What can we do? And what can we do is to vaccinate as many people in the community, to vaccinate as many children, 17 to 12 as we can, and continue to do the use of masks.
Thank you both very much. We have another question. Can we discuss at all whether our health system, or if you're aware of other health systems who are prescribing ivermectin for COVID treatment or prevention?
Go ahead.
I can take that one. So obviously, it's amazing to listen that something that has never been proven to work, that has even, I have a close colleague who trained with me in Dallas, who is an infectious disease doctor in Colombia, who did a randomized, double-blind, placebo-controlled trial to test whether ivermectin was preventive or not for COVID. And they did it because in Colombia, that was a big deal, and a lot of people were arguing that that could be an effective tool. Well, they proved, and this study has been published in JAMA, a very serious medical journal, that does not work. So not only there is no reason to think that it will not work, it has been tested and proven objectively that it doesn't offer any benefit.
And Dr. Romillo, can you just explain what that medication is and how it is used?
Yeah, very good. Ivermectin is a medication that we use to treat worms. It has nothing to do with viruses. And not only that, some people, we heard that they are taking the medication that is developed for cows and horses, not even the formulation that is available for humans. So I understand that we all want to find shortcuts, but unfortunately, ivermectin does not have any benefit, and the FDA has published an announcement because there have been some side effects because the people took big doses that were not recommended for anything.
Thank you very much to the both of you for answering that question. Another question that we have from 10TV, what does it say that there is one child with no underlying condition in the ICU with COVID-19?
I think what it says is that children are not immune to getting COVID, that you can be perfectly healthy and you can actually get this disease as a child and become critically ill. So if you are a parent who thinks that my child's healthy, they have no underlying conditions, I don't need to mask, or I don't need to get vaccinated, or I don't need to get my children vaccinated if they're eligible, it would give me pause as a parent to take a step back and reconsider that decision. It is an opportunity. Getting vaccinated is an opportunity, as well as masking, to help protect yourself from being ill or your loved ones and ending up in the ICU.
So can I add some comments onto that? So we have looked at our experience since April of last year, right? To look at our numbers, and we have analyzed that very, very carefully. Number one, children have a lot of virus. So this idea that children don't have virus, they do have a lot of virus. We can measure a lot of virus in the respiratory tract. We have seen that depends on the age groups. For instance, among the older teenagers, 20% were previously healthy. But if you look at kids under 5 that we had hospitalized as children, 60% were previously normal. So that means that although it's a small percentage compared to adults, perfectly normal children, we've never had a disease, we've never been sick, we have a very strong immune system. Those kids can get also very sick. It's not just the initial idea that will be the kids who have some chronic conditions or receive chemotherapy for cancer. And that's a very important message. Again, for your child, if he or she gets it, it's 100%.
Thank you very much, both of you, for addressing that. I have a couple other questions, specifically for Dr. Romillo. I know we're getting short on time here. We have about 3 minutes left in our briefing, so I just want to offer these last couple. If there are any other final questions that members of the media want to submit, feel free to do so. Dr. Romillo, you had mentioned bronchiolitis earlier in some of your remarks. Could you talk about the difference between RSV and bronchiolitis, and then could you address differences between RSV and COVID?
Excellent. So bronchiolitis is the infection in the lung, and that happens in young babies because they have what we call the bronchioles. These are small airways that get inflamed. So it's a form of pneumonia that happens in young babies. 80% are caused by RSV, but there are other viruses that can cause it, like rhinoviruses or parainfluenza viruses. So bronchiolitis is the infection, and RSV is the cause, the virus that causes the infection. That's number one. Number two, you asked me, the difference between RSV and COVID. Well, we've been studying RSV for 40 years and COVID only for 18 months. Something that is very unique is that the younger the babies, the more severe they get infected and symptoms with RSV. With COVID, it's the opposite. The younger babies, there is something unique that makes them more resistant, if you want. Not totally, because we have kids as young as 2 months old admitted to our ICU, 2-day-old. But somehow there is something unique that the older kids, the teenagers, and the adults do worse with COVID. We need to understand that. It's a very important goal of our research that we are working on it, but we don't understand that very clearly. There are two different viruses. They are similar in terms that they are transmitted through the contact and with droplets and aerosols, but there are two different families of viruses on that regard. They both infect the respiratory tract, but 20% of the kids with COVID, we can find the virus in the blood, and we never do this with RSV. So COVID is more severe in global than RSV is, unfortunately.